Well, good afternoon and welcome to BurnCast episode number 4, where we're going to be talking about the importance of feeding. Of course, we have Anne and Liz, but today we have a special guest, Kayla Bergman. She's a registered dietitian who primarily works in the pediatric ICU and also with our metabolic kids. Anne is going to get us started today of talking about the need to feed.
The need to feed. Yeah. Hi, I'm Anne. I'm one of the burn nurse practitioners. I know we've done some BurnCast before. I think kind of our number one thing to say is that nutrition is really important in burn patients, and we want high protein, we want high calorie. We really want to make sure that we get kids fed through the gut when possible, as soon as possible, because nutrition helps with burn healing, and burn healing is our goal in these patients. So I personally usually listen to what Kayla asks me to do in terms of specifics when it comes to managing feeds and supplements, and we'll go into that a little bit more. But usually our goal is to get an NG tube into our large burn patients, so like 15% and greater, or even anyone who's admitted with a burn, to get NG and enteral feeds initiated within the first 24 hours of after the burn.
Why is the gut the most important part? Like, why can't we just like put all these kids on TPN and call it a day? Like, why is it the gut that's so important?
I mean, Kayla can probably give you more specifics on this, but you absorb a lot better nutrients through the gut, and you're able to give a lot more complete nutrition through the gut in terms of everything that the body needs. It's just not as rich and as dense as what you in TPN or parental nutrition as what you can get in through the gut.
Yeah, so feeding the gut is really important. If we think about our intestines, those cells are turning over every 3 to 5 days. So if we're not using them on a regular basis, they start to lose some of that function and that ability to digest and absorb things. So not only do we have really high nutrition needs with burns, but we want to make sure that we're using our gut and we're feeding these kids and making sure that they're going to continue to be able to use their gut as it's meant to digest and absorb these foods. When we're thinking about things like TPN, that carries its own set of risks. So you have a higher risk of infection. You have a higher risk of electrolyte abnormalities. A lot of times there are shortages that might affect what we can put in a TPN. So really making sure that we get the best complete nutrition, we should be using our gut whenever we can.
Is there ever a reason that, so say a kid has a burn in their, their diaper area, and, the more you feed, the more you're going to soil that diaper area. Is that anything that we ever worry about with feeding kids with burns in those areas?
I think we often have actually the opposite problem, in that usually our burn patients are on pain medication. So we tend to block them up and need to start bowel regimens in the beginning, but we don't want patients to have diarrhea for whatever reason. So we will deal with it if we cross that bridge, but usually stool is not a reason to stop NG feeds, unless somebody's having GI distress or not tolerating feeds, or having, that is a reason to stop from like an actual like abdominal intolerance to the feeds. But the physical stool in a burned area, we have ways that we can try and protect that, to change diapers easily, or as easily as possible for the child. And I think we actually end up with patients constipated more often.
So, Anne, you brought up a really good point. When we talk about feeding intolerance, Anne and Kayla, what kinds of things would we see with feeding intolerance?
Feeding intolerance can give you emesis. It can give you diarrhea. One of the biggest things is abdominal distension. And then a lot of our burns are actually younger burns. We see a lot of still scald burns in the under 2 population, and they can't always verbalize what they're feeling. So sometimes just irritability can be a sign of feeding intolerance in a baby. And And anything where you're really escalating pain regimen or pain management, and you're not changing bandages frequently, or the patient's in a long acting dressing, it's probably worth asking, like, is this actually pain from the burn? Because burns are painful, but sometimes it's actually feeding intolerance.
So you
Stop feeds and then
Mhm.
really conservative.
So the kids that obviously we are always worried about burn kids, or children with burns needing adequate nutrition. Is it does every single admitted burn get an NG tube?
I would say not every single patient. So if a patient's able to, and we do have a protocol that talks about the different percent of total body surface area, and when we initiate an NG tube and when we allow patients to try and PO. Some patients are, have a less than 5% burn and they're eating okay. And so we don't have to initiate with an NG tube.
So how can we help our bedside nurses know who needs an NG tube and who isn't? Is there like a clear line in the sand?
I would say go to the protocol. I know that's kind of a little bit of a cop out, but we have it established and it's really well written out. Do I have it pulled up?
Yeah.
That's a great question.
I want to say 10% for the younger children. But
So
again,
any burn over 10%.
Calorie count is incredibly important for every admitted burn. If a burn is admitted, we're pretty liberal about some of the patients that we send home. But if a burn is admitted, they certainly need some extra attention, especially, making sure they're getting adequate caloric intake.
Kayla, how often do you see our burn children with NG tubes?
I would say that if it's more than 10%, we're putting an NG in place. Definitely if they're like less than 5 years old, at the 10% mark, we have an NG in place. For the older kids, it might be closer to that 15% before we're putting in an NG tube. But really, we want to make sure that they can meet those calorie needs and that they can take enough in by mouth and consistently enough to make sure that we're meeting their needs. So the kind of under 5 population, those kids, it's hard. Even a healthy kid at home is going to eat completely different one day compared to the next. And that's just a developmental thing. We know that happens. But when you're really trying to get kids to make sure that you're meeting their nutrition needs to help them heal, it becomes a lot easier with the NG tube in place.
Can I share my screen?
So, yeah, please do.
Okay.
I was looking forward to
it. I found it. I beat you. I found it. Hold on.
So we know that like any kid that goes to the ICU, that would be a burn 15% or greater. All of those kids will have an NG tube.
Yep.
Yep. So this is within our trauma and burn manual, which you can search for on the intranet, which is what I did, trauma and burn manual. And then when you click on it, there's a link to the updated version, but this is our updated version. And you can see if less than 10% evaluate for the patient's inability to meet PO versus tube feedings, if less than 24 months, place on admission. And then it kind of breaks into the different TBSA, whether or not you're, and ages, whether or not you're allowing them to, like, this is the initial, you're going to get official nutrition recommendations that are going to help point you in the right direction of, once we've gotten some labs and we're, on day 1 or 2 or kind of after that initial, but this can kind of give you a good idea of, that's our fever guideline. This is our nutrition guidelines, of what to do when a burn first comes in.
So, it's interesting. One thing that I'm noticing on the burn nutrition guideline, and Kayla, you might be able to explain this, is it says do not use fiber containing formula. Why not?
So fiber containing formulas, some people don't tolerate them as well as others. So some people, when they have extra fiber that they're not used to, they can make them feel kind of bloated. For some people, it gives them diarrhea. Sometimes the fiber containing formulas are nice if we know that a patient is constipated to help them get some extra fiber, but we really want to be taking that on like a case-by-case basis because you have just this higher risk of not tolerating your feeds right away if we are using a fiber containing formula.
And okay, so the dreaded NG tube. So we don't put them in the emergency department. They're always put in on the floor or in the ICU. Do you have any suggestions on how we can keep these NG tubes in, because, our kiddos, if they throw up, sometimes, they'll throw up the end and it'll come through their mouth and they'll still have it stuck to their nose. Our kiddos with facial burns, which is a lot of our spill scalds, their faces are burned, so there's nowhere to put tape. Do you have any tricks for the trade, or any special tools for that?
So if a patient has facial burns, I think it depends on a few different things. One would be if they have facial burns to the entire face. If it's really only one side of the face, you can sometimes tape onto the other cheek. If the patient is intubated, sometimes if you're in the ICU and their facial burns and the patient is intubated, we often try for a nasal ET tube because it's hard to secure the oral one. If that's the case, then our little trick that I'm going to show you doesn't often work with a nasal ET tube. But if a patient truly has facial burns, we will try and put in, and I actually have this one ready to go, a nasal bridle. This is placed in the pediatric population. At least for us, we usually place this in the operating room when the patient goes to the OR or is under their first sedation, either in the ICU or whenever we can get them pretty still, because it is a bit tricky to place. But what's happening is this is a nasal gastric tube securement device. So it comes completely separate from the NG tube. It is placed with a stylet and then a magnet on the other end. So you can see here that the stylet has a magnet on one side, and then you pull this it's almost like a little rubber securement device through the end of the nasal septum, and then it comes back through and it goes into this clip, and the clip secures the NG tube, and then this it's almost like a piece of floss, but it's bigger than that, and it's like a silicone into this clip, and then you tie it, and you don't have to tape to the patient's face. It's secured over the nasal septum. We use these, it only works, the one that we have is for 8 and 10 French nasogastric tubes, so we have to use one of those two sizes. But we will place these on patients who require them for either facial burns or kind of sweating off. They're unable to keep an NG tube in. They can still throw it up from their mouth because it's secured through their nose, but it's really good if you have issues with facial burns and securing it to the face.
Do you use this device with a special NG tube, or can you use it with all NG tubes?
Just our regular 8 and 10 French NG tubes, so it doesn't have to be a special NG tube. It is a special device that comes from, we have stocked in the operating room.
Is the device MRI compatible?
I'm 95% sure, and I think that's what this MR maybe means, but I would do some deeper digging onto their website to make sure. And this website has a lot of really good information. AMT is who makes it. They also have a link to, here is their,
that's cool.
They have a video that speaks about, that looks into the different types of bridles that they have, and you can look at the one that we have, as well as how to insert it. So this, let's see, I don't want to show you the whole thing, but I believe it's MR compatible, but you can see that they're bringing the other end through, and then you secure it as with your NG tube. I believe that it's MR compatible, but I don't want to tell you 100% if I'm not reading it directly off of here, but I believe it is.
Do we use these with most of our kids?
Most of our facial burns, if it truly, you can't secure it to their face. But if somebody's nasally intubated, you can like secure it to to the ET tube securement device. Like this is hard to, you can't insert this with a nasal endotracheal tube. So you can have an NG tube in one nair and the ET tube in the other nair, and then kind of secure your NG tube to other parts of it.
Is there, are there any contraindications of using this?
I think if you had a nasal septum problem or
facial trauma.
Yep.
Burn's not included in the facial trauma.
There you go.
Well.
Correct. Skin, fine, yeah.
Okay, so we talked about we obviously have a need for feed, the need to feed, and those are like generally the devices that we're using to get the feeds in. Kayla, what would you say to all of that? Like, what do you feel like are the important things for our bedside nurses to understand about that? Because you know, I feel like nobody really wants to push a burn child, particularly in like NG placement can be uncomfortable. A lot of times the thought is, oh, we'll wait till the OR and have the nurse practitioners put it in. So that's, you know, maybe like 12 hours later if they're having trouble. Like, what do you have any thoughts or like the importance or anything like that?
It's great if we can start feeds as soon as possible, because if you think about before you go to the OR and you have that kind of open burns, you're losing nutrients through them, especially your micronutrients. So things like zinc and vitamin A and vitamin C, and you're losing protein. So the sooner we can start replacing some of those nutrients, the better off we're going to be. I know sometimes it's hard to place that NG tube and to get the cooperation to be able to do it. But it really is very important that we get these kids to their goal feeds as quickly as possible, so that we really are helping that healing process.
Speaking of nutrients, can you speak to what we use in addition to just straight up NG feeds, supplements, nutrients,
Sure.
labs, etc.?
Yep. So for all of our burn patients, we're generally starting a multivitamin, which when we're starting depends a little bit on the age of the patient. Generally for burns greater than 10% and definitely for greater than 20%, we might ask to check some additional labs. So we might check things like zinc levels, copper levels, selenium levels, vitamin A, vitamin C, and vitamin D. We will replete, so we'll give extras of those supplements and those vitamins and minerals if the patient's labs are low. Most of our patients that come in with more than a 15% burn are going to have low levels of some sort of a nutrient. And then we continue those supplements for a couple weeks. We monitor their labs, and as those labs start to go back into normal limits, then we discontinue the extra supplementation. But that's just to help support healing.
That's a lot.
It is a lot.
So you listed like 5 or 6. Can you go through those again? Just so,
Yeah.
because I think that's interesting for like all of us to know. I would think that, you know, we put up the bag, we run the feeds, but knowing all of the different things again, I think that'd be helpful to hear.
Yeah. So vitamin D is the most commonly one that we check, and then zinc as well. Other ones that we might check are vitamin A, vitamin C, copper, selenium. And then if we are supplementing with zinc or selenium, we'll also monitor iron levels, because all of those interfere for the same binding sites.
Do you generally put all kids on the same formula at different calorie contents?
It varies a little bit. So we try to think about what's going to get us the most nutrition and kind of without giving too much volume. So a lot of our littler kids, we're using things like Boost Kid Essentials 1.5, which means it has 1.5 calories per ml, and that helps them meet those increased needs without giving them too much fluid and making them feel too full. For some of our older kids, we might be doing like a Nutrin 1.5. If kids are intubated, I'll often use Replete because it's 25% of its calories are from protein. So that helps me give them that protein that they need without giving enough calories, but then assuming that intubation also decreases your calorie needs. So that one becomes a little bit of a balance between giving them enough nutrition without giving them too much. That one's a nice formula to use. And then we also have protein supplements and modulars as well. So we have things like ProSource, which has 11 grams of protein in a little packet. We have things like Beneprotein that can be added to feeds or to foods as well. And then for like babies, we have something called Liquid Protein Fortifier, which is a protein modulator that's designed specifically for less than 1 year of age.
So generally speaking, are these all specially made formulas that come from the formula lab, or are they going to just be in like the bags or the containers that you just pour into a bag?
Usually they are just kind of ready to feed,
Okay.
that are already available that we don't have to do any mixing. Occasionally we might have to add some, if they have really high fluid needs and we have to add a little bit of water, we might have to do some mixing. Or if we use protein, that's one that generally will mix into the formula just because it makes it a little bit easier to administer. But generally it's just going to be the straight out of the can or the feeding bag.
Kayla, I just thought of something. What if a child is breastfed? How does that kind of play into everything?
That's a great question,
Or-
especially since your kids are so little.
Mhm.
Yeah.
That one is really tricky because breast milk is lower in protein than most of our standard infant formulas, but the protein is better absorbed. And you're also relying a lot on what is mom's diet to know what nutrients you're getting. So in that situation, I think we'd have to work out a plan of making sure that we're maybe doing a combination of some breastfeeding and some formula, just to make sure that we really do get all those calories that we need and all that protein that we need to support healing. That would be a situation where liquid protein fortifier would be a great addition because it's meant for those little kids that you can just give them like 30 mLs twice a day or something like that, and just add as a kind of like an extra feed. But they would probably require an NG tube.
I'd also like to make a plug for once the patients are taking some by mouth, we still supplement with NG feeds, but calorie count is really important. And I know it's not a bedside nurse's favorite thing to do because I think, trying to keep a really close eye on every little piece of food that a patient is eating, especially if the family's involved, to track everything, maybe keeping a log or whatever it might be. Because the more that they eat, the lower NG feeds as they're getting better, we can give them, and the family always wants to get the NG out. So the sooner they're taking it by mouth, the sooner we can get them off of the NG. And the calorie count is really important for that.
How do you explain to parents who are already traumatized over their child's burn, the hospitalization and all the thing, that now we're going to stick a tube down their kid's nose, and they'll probably be there when our nursing staff is trying to put it in, and it's never pretty. What do you say to parents to make that okay with everyone?
I always stress the importance of wound healing and that nutrition is just our number one, and that even if we give the patient a chance to try, they usually can't meet the goals within the first few days because their body is really trying to work on healing and fluid balance and a lot of other things. So that we try and get it out as soon as we can, but that it's extremely important for our wound healing. And usually we can come to an agreement when we realize that it helps expedite the healing process.
Is the need for an NG tube like part of, we have all these mental checklists that we go through in our day-to-day. So if you have a kid that you're doing a dressing change in the operating room and they're sedated, is it something that you think of as a provider of looking at the kid and going oh wow, they don't have an NG tube, they should have one, I wonder why they don't, or getting that information before? Is that part of the provider process when going to the OR each time?
Yeah, I think it depends on the size of the burn and when the patient's going to the operating room. Usually that doesn't, for big burns, that doesn't always happen within the first 24 hours, especially if they're admitted to the ICU. So ideally they have the NG tube in before they go to the operating room. But if it is a patient who hasn't had one placed yet and we're in the operating room, it's usually a discussion, or we placed one, we couldn't secure it to the face, it came out 3 times or something, very traumatizing like that, then we're looking at a bridle. And so ideally it's in within the first 24 hours, but if it's not, then it's definitely something that we can consider putting in the operating room under sedation for sure.
Almost like they have to prove that they don't need one, right?
Yeah. Yeah.
What how many more calories a day does we'll say a burn patient with a 10%, a 5-year-old with a 10% burn, how many more calories do they need? Is it twice the amount, and it doesn't have to be an exact, is it 2.5 times, 3 times?
For like a 5-year-old with a 10% burn, it'd be an extra, let's see, 400 calories a day.
That doesn't seem like a lot.
But depending on their weight, so let me just think about what my
But for a 5-year-old, it might be.
5-year-old, it might be.
Yeah, I'm trying to think of like better ways that like it's like an easy way to explain to parents of like, hey, when your kid, since your kid has a burn, like their body requires twice the amount of nutrition. Because you know, we're not going to be able to like tell them all of the different nutrients and label each one and say this many aliquots of this and this and this and this. Like,
Yeah.
I'm trying to find a good way to like say
I
this.
I also like to say, like, you know, when you're sick and you don't feel very well and you're like, God, I haven't had anything to eat all day, but I'm not that hungry, or like you're not really seeking out food, you're trying to stay hydrated. Like it's a lot for you to try and just like get off of the couch when you have it's not exactly the same, but your body's stressed and trying to work on healing, and you can't always prioritize feeding yourself or eating. And so I try to explain that as well, that like we want to help with the nutrition because it may be too much to put on them to be the primary driver of the nutrition. Plus they have extra needs.
Sometimes I'll explain to families the extra needs in terms of like how many extra like Pediasure would you have to drink per day on top of what you would already normally eat. So if it's a 5-year-old with a 10% burn, that's almost 2 full cans of Pediasure a day in addition to what they typically would be eating. So imagine trying to get that kid to add almost a full another meal to their day, sometimes 2 meals based on how much they eat at home. So
I feel like I barely get my kids to eat 3 meals per day, let alone a 4th run. So right? Toddlers, they're hard.
Kayla, can you just run through some of the common supplements since we just talked about Pediasure?
Yeah.
What could nurses expect to have,
sure.
You know, in addition to a high calorie, high protein diet?
So for our kind of 1 to 13-year-olds, we carry Pediasure, and then we have Boost Kids Essentials in both a 1 and a 1.5 variety. So the 1.5 variety has more calories than the 1. For our older kids, we have Boost and Boost Plus, which is the same sort of thing where the Boost has about 1 calorie per ml, where the Boost Plus would have 1.5 calories per ml. So more calories in a smaller volume. And then for our kind of clear liquid style supplements, we have Boost Breeze and Ensure Clear. And both of those have 1 calorie per ml. They're kind of like,
I love those.
Apple juice flavor or berry juice flavor. So those ones are kind of nice when you have kids that you're like, oh, they're drinking a lot of apple juice. We could switch this for an apple Ensure Clear and they'd at least get 7 to 9 grams of protein in this cup that they're drinking.
I think those are great for the little kids who are like, they just drank apple juice all day. It's like, well, let's use Ensure Clear instead. And they're getting more nutrient, like even those little swaps or even half and half or whatever it is. So sorry to interrupt you, but I do love those as not our number one, but like when you're really struggling to get kids.
Yeah, and anytime I'm always happy to send sample trays to our patients. So usually when I'm like, okay, we're going to start a diet today, what flavors do you like? And I'll just send up a whole tray and be like, let us know, try different ones. Even if you take 2 sips, that's better than nothing. Because there are a lot of different varieties.
There's shakes and something else similar to a shake that I ordered under the shake the other day. I don't remember what it was.
So we used to have Scandi shakes, which they just discontinued. So it's being replaced with something called Nutrish, which is like a packet of powder. I think it's chocolate and vanilla flavor, and you mix it with like milk and ice cream, and they're pretty delicious. The dietitians tried them not that long ago, and they're a great way to add some extra calories. Have a milkshake. We can add different flavors to those as well to make it something appealing to each individual patient. But you can pack a lot of calories into one of those.
And if a family could bring food from home, what do you recommend that they bring?
If they can bring in high protein, high calorie food. So if we think of our protein sources, things like meats, nuts, seeds, our dairy products are high in protein, but really anything the kid likes. and will eat is great with me. And this is another reason why our calorie counts are so important, because the more things and the more variety of foods that the dietitians know that the child is eating, the sooner we can wean those NG tube feeds.
That's good to know. Do you encourage families to bring in food?
Yeah, we're always welcome to have them bring in things. If there's something that they know that their child will like and will eat, that's great. The only things I kind of worry about are things like juice, which have a lot of calories but not a lot of protein. So if there's other things we can do instead of that, like the clear supplements, that's always great.
Have you tasted the supplements?
Yeah.
I haven't tasted any formula, so I have no idea. Like I've tasted.
Maybe we should do a tray sampling taster one time.
Yeah, we should, because I have
Yeah,
no idea.
so we know what we're pushing on kids.
It's a good idea.
Yeah.
I mean, I tried steroids once because I didn't understand why every kid was like fighting me on like methylpred.
Mhm.
Have you had it? It's disgusting. It's
I have
so
not,
bad.
but
It's
from the reaction,
terrible.
it seems
I
like
just
it
had
must
people
be.
throw it up on me.
Yeah,
Yeah,
one day
exactly.
one day I tasted it because I was like, what is happening? And I was like, I can't believe we try to
Okay.
get people to drink this. So and back to that, Kayla, have you tried the
Yeah.
clear stuff?
Yep. The clear ones are very sweet. So you
Okay.
have to really like that kind of sweet juice type flavor. Some of the like Pediasures and Boost Kids Essentials, those ones, they're still pretty sweet, but they're not quite as sweet as others. And then we also have some Kate Farms supplements as well. And those ones are on the less sweet end of things. So there is quite a variety, and we're usually able to kind of figure out something that the patient will enjoy.
For NG feeds, will kids get an aftertaste of what we're putting in them?
Most of the formulas have kind of like a vanilla flavor or a plain flavor, so they don't generally taste it, but they do have a little bit of a kind of a vanilla neutral flavor to them.
Yeah, I feel like I've always wondered that.
Mhm.
And while we're talking about formulas and getting them into kids, there was one thing that happened to me at the bedside all the time whenever I had anybody on Beneprotein or Benefiber or anything extra, it clogged the pump.
Yep.
How does a bedside nurse unclog the pump or prevent the pump from clogging?
So making sure that we're flushing with adequate water is really going to help with those. A lot of those protein modulars, they will clog that tube if you don't give enough water with it. So I think the Beneprotein instructions actually will tell you to flush with like 15 to 30 mLs of water before, and then mixing it with adequate water. So a couple ounces of water, and then flushing the tube afterwards. We do with Beneprotein, oftentimes we'll end up mixing it into the formula, which seems to help a little bit. I don't feel like I hear quite as many instances of that tube being clogged, but if we're not flushing our NG tube regularly, it does have a tendency to get clogged.
So if a kid's on continuous feeds,
Mhm.
what would you say to do, like every 4 hours, just do a flush, or
Yeah, every 4
okay.
to 6 hours, if you're giving meds or something like that, just do an extra like little water flush
Okay.
just to help keep that tube clear.
Yeah, I feel like that might be helpful, because I have definitely been the one. I was like, oh my God, what's happening? And the last thing you want is to have an NG tube in place that's clogged.
Mhm.
That's a sad day for everyone.
Yeah.
It's like the tube's in place, everything's good, and you're like,
Mhm.
there's cement inside of it. If it is clogged, do you have any other remedies other than like water that are, okay, not off the book, but like
Mhm.
legit remedies to unclog an NG tube rather than take it out?
I don't think I have any great ones.
I-
I've heard, tales of
Yes.
some, but I don't know if they're on the books or off the books. So
Right.
I'm not going to share.
I would agree. I have lots of like things I've heard over the years, but I'm
Yeah.
not sure that you really should be doing them.
I know the smaller the syringe, the more force you get, right?
Okay. That physics tracks, I think, but I didn't do very well in physics, so.
Oh, one thing I wanted, when you were talking about a clogged tube, which makes me very sad, I forgot to mention that with the bridle, the clip because obviously you don't want the child to be able to unclip it, is unclipped by basically a guitar pick. And it comes with the bridle itself. I wonder if I can find the picture. Hold on, I'm going to share my screen again. We on surgical care have an extra one in the NP office, and we also have one, I think, in the like fishbowl. Let me see if it, there it is. Oh, nope. There it is. There it is. So this is the little purple pick that it's like a red, pink, purple. And that's how you pry open the clip. So if you needed to, if you needed to adjust the depth of the NG tube or something, the bridle will still stay in, but you want to make sure that you have the clip in order to get it out, to open it up to move the NG tube. When you close it, and I'm speaking from experience here, you want to make sure that whatever area the bridle string is supposed to go through, that it's through. So if the NG goes here, sometimes the bridle goes like actually in the little clip part. And I think that's down here in the video. The video also very much explains this. So like these look different. We have the Pro clip, and this second string, one is attached to the bridle itself. The second string goes into this little area. If you pull it, it shouldn't move, right? Which is kind of like a duh moment, but I've done it wrong before. And losing a bridle is not great. So if you're unclipping the bridle, just make sure that you have the guitar pick or whatever you want to call it, the pick to open it up. And then that when you re-secure it, that you're securing it without like obstructing your NG tube into the clip, that it's going through the NG path on it, and that you're getting the second bridle string into the clip so that it's not moving. And I find this website extremely helpful because you can look up the type of bridle that you have and look through the instructions. We also, when we place them, I always send the instructions and the pick back with the patient's chart. So that would be something to keep on the patient's chart. But if you happen to be troubleshooting a bridle.
And how did you get to that website? I want to make sure that everybody who's watching this could go to that.
Okay.
Do they just Google AMT bridle?
Yeah, you should be able to.
Wow.
I think that's what I did. I think I just went to, let's check Google. Bridle, not Bridgerton. Oh, that's probably not the right way to go. AMT. Yep, right there. AMT bridle.
Okay.
And I think there's a way in resources, device instructions for use and resources. This is usually where I find they have a number of other things, but this is the Bridle Pro. So you can go straight to the instructions. I think this might be the instruction manual that it comes with. So that speaks to where you clip it in if it loads. Maybe it doesn't. I'm on the VPN, so maybe that's the problem. Oh, here it is. So this is the instruction packet that actually comes with the bridle itself. And then it speaks to where to clip it in and using the pick to open it and how to remove it. You cut the bridle string to remove it. And then I think within the resources, they may have a link to the video right here. Here's the video, which is also on YouTube. If you type AMT bridle, you can find it on YouTube as well. Really helpful website if you're looking for information on the bridle.
Yeah, I think that's great.
Mm-hmm.
Does the bridle decrease the circumference of the tube at all?
Of the NG tube?
Yeah.
I don't think so. It has a clear path as to where the NG inserts. I think it squeezes it just enough, which is why you can only use the 8 and 10 in the 8 to 10 bridle.
Okay. All right.
I have a question for Kayla. Kayla, when do you determine that a kiddo who's on continuous feeds is ready for more condensed feeds?
Sure. So we think about a couple of things. How much volume are they getting? And how often do they need to be NPO to maybe go to the OR or for dressing changes? And how kind of big are they? So we think about how much volume can they tolerate at one time to go to bolus feeds, or how many hours a day do we have available to us that we can give them feeds? And then how big are they? So that goes back into how much volume can they tolerate. There's kind of some general guidelines for kids of a certain size should tolerate feeds at about this amount. So that's usually where we start. A lot of times for these kids, we can, with a more concentrated formula, we can kind of condense those hours a day so that we're maybe meeting like 50% of their needs overnight or 75% of their needs, and have the feeds run overnight while they're sleeping. So that gives them the whole day to be able to eat as able, so that we can adjust those. The bolus feeds are nice if we think that they're going to be majority NG tube fed for a long period of time. It gets a little bit tricky in the inpatient setting when you're trying to have somebody eat and give them boluses as well during the day, because then you're like, okay, so they're due for their bolus, but they haven't eaten lunch yet. And then they get their bolus and they don't want to eat lunch, or our bolus is delayed because we were waiting to eat lunch and then we didn't eat very well. So it kind of ends up being a little bit tricky from a timing standpoint to do the bolus feeds in these kids, just because we do want to make sure that they're getting all of their nutrition in. But doing kind of some overnight feeds with letting them eat by mouth during the day seems to work pretty well.
So Kayla, Ann, and Liz, I'm gonna ask you guys all the same question. I'm gonna start with Kayla. What would you say is the one thing that you find the most important for a bedside nurse to remember about the importance of feeding in our burn patients? Like everybody gets a take-home point.
To make sure that we're documenting the I's and O's. Because without knowing what the patient is taking by mouth, I can't adjust those NG2 feeds. And I often find nurses saying, oh, I think we're overfeeding them. I'm like, but there's nothing documented that says that they're eating anything by mouth. So from my standpoint, they still need all these feeds. So if you can write down anything that they're eating, that way it gives us documentation and evidence so that we know, okay, we're at a good place where we can come down in our NG2 feeds.
Every burn patient should be ordered for a calorie count. So if they're not, please ask for one. It's in our burn order set. So hopefully you will be getting not just your strict I's and O's with NG feeds, but your calorie count as well for anything they take. So.
And again, the emphasis on how crucial this is for wound healing. If the child does not have that nutrition, they're not going to heal donor sites. They're not going to heal that burn primarily. But I also think it's important to think about, when the burns finally have healed. We do have a subset of patients that are still in-house when the burns have healed. So maybe, there's a chance there to kind of back off a little bit, but certainly in the acute phase, it is absolutely crucial to optimize wound healing, to make sure that we have proper nutrition and enteral nutrition if needed. So although the NG may not be too popular, again, it's really essential.
Okay, well, thank you guys so much for joining us today. And thank you, Kayla, for being our special guest. If you ever have anything that you want to talk about burn wise, come back.
All right.
Yeah, thank you, Kayla.